Good afternoon, everyone, and welcome to McGill Cares, a new weekly webcast series designed to support informal caregivers and family caregivers. My name is Claire Webster. I'm a certified Alzheimer care consultant, a former caregiver, and founder of the McGill Dementia Education Program. Today, we will be discussing support and safety during the COVID crisis. According to a recent article published in the Montreal Gazette on May 19th, entitled Seniors Caring for Seniors Are the Pandemic's Invisible Victims, an opinion piece that was written by Tamara Sussman and Shari Brotman, associate professors at McGill School of Social Work. The article highlights the following. Senior caregivers are among the essential frontline workers struggling on a daily basis to keep our healthcare system afloat while putting themselves at risk in the process. Yet they are left alone, invisible victims of this pandemic. In communities, family caregivers have silently provided almost 80% of the hands-on care to seniors for decades. Senior caregivers, who are a high-risk group due to their age, provide more average weekly care to other seniors in Canada than their younger counterparts. These caregivers are working tirelessly on the front lines of this pandemic without recognition or support. Today, I have the great privilege of interviewing my colleague and friend, Dr. José Morais, professor and the Director of Geriatric Medicine at the McGill Faculty of Medicine. In addition to being the academic lead of the McGill Dementia Education Program, he is co-director of the Quebec Network for Research on Aging and past president of the Canadian Geriatrics Society. Welcome to our show.
Good afternoon, everyone. Good afternoon, Claire.
Good afternoon. So first of all, I'd like to acknowledge that, this is an incredibly important topic that we're going to be addressing today. And you have been on the front lines of the COVID crisis in the hospitals. How has that been going?
Being a physician, I was called to provide care in our COVID units. And I must confess that it's a type of practice that is a bit technical. We have to follow protocols. We have to have our protective equipment. What I found most difficult is the fact that we couldn't have a very humane interaction with our patients due to the equipment, as well as precautions we would need to take. I found this hard because the core of the practice of geriatrics is to be very patient-centered, very close to our patients, a lot of exchanges. And this was particularly difficult in the setting of COVID and precautions to be taken,
I can imagine as well for you and your team to witness also, there must have been quite a few deaths in the hospitals, and that must have been quite difficult to experience on a regular basis.
It's always the case, obviously, when we lose a patient, it's a kind of a failure in one sense, though we are cognizant of the fact that we all have limited lifespan on Earth, but still we are affected. We are affected also to realize that there is a lot of frailty amongst these patients. Those on CHSLD are very dependent for self-care, and they require a lot of attention. So I only can congratulate all the healthcare workers in these long-term care facilities who devote their lives to care for these very frail, dependent older adults.
Would you have imagined in your career span that you would have been faced to go to the front lines for a pandemic? I mean, was this something that you had trained for or prepared for?
Well, in general, physicians are trained to deal with acute things. Being a geriatrician working in the hospital, we are more exposed to this type of acute treatments of conditions. However, the pandemic is a total different ballgame. By the intensity, by how fast a patient can deteriorate, the limitations one have to treat them, because there is no treatment. What we have is supportive treatment, but no final treatment to get rid of the virus. We have to wait for the immune system to take over and combat and fight off the virus itself. So this was very experiencing for us, because we're mainly assisting. We are not curing,
I've had a lot of exposure to healthcare professionals throughout my life, caring for two aging parents. And and we've known each other now for the past couple of years working together. And I have to say, you are one of the most compassionate and kindest healthcare professionals I've ever met. It's very clear that you really love your job. Like, what motivated you to become a geriatrician?
This is a good question, because the choice of a career, there is so many factors intermingled that it's never so clear. However, I would say that in your studies, in your training, you come to meet with people who can serve as role models,
Mm-hmm.
and the combination of these role models with opportunities in life and a particular sensitivity of the person. And in my case, I did meet a geriatrician when I was in Université de Montréal, who was a good role model, Dr. Charbonneau, who have passed away already. And when I came to McGill, there was another physician, Dr. David Gayton, that played another role model in my career. And this probably, along with experience that I had had with my own father, were suffering
Mm-hmm.
from dementia, and unconsciously, it might have led me to choose to become a geriatrician, which at that time, 30 years ago, was probably the subspecialty that would most understand what dementia was.
Mm-hmm.
Since then, there is other subspecialties devoted to caring for dementia, as neurologists, geriatric psychiatrists. But at that time, geriatricians were really preoccupied in dealing with patients with dementia.
So, in addition to memory issues, which we're going to get into a bit more, what are some of the most common health conditions that you see older adults in your clinics with?
Yeah, as one ages, the number of chronic conditions increases tremendously. So older people have, 40% of them have more than 5 chronic diseases. But I would say the best answer for you is to verify with older persons what they feel is most important for them. It's not just a question of having more chronic diseases, as what is most important for them. And in fact, what they tell us, and there's many questionnaires and surveys confirming it, is that they want to remain autonomous. Mm-hmm. And to achieve that, it's quite clear that there is 2 different paths through which we can maintain our autonomy. One being the cognitive capacity, and this is then dementia interferes in that aspect. Whereas mobility is also a very important aspect to maintain our autonomy. Mm-hmm. And physical capacity that enables one to be mobile and self-sufficient in this aspect requires good general health, and older people are affected by heart, lung diseases, etc., but also having the good joints. So arthritis affects that, and strength and balance. So muscle mass, muscle capacity, all of this enables the person to remain autonomous as long as possible in their own environment. Older persons would wish always to stay in their homes, not always possible. And the majority of them, when they reach 80 and above, require the assistance of a caregiver, mostly family members, the spouse and children.
So now, I can just imagine with the COVID crisis, many of your patients would probably be afraid to come to the hospital or come for follow-ups. How is it working now in terms of supporting these patients who need to be seen? Like, what can people do?
Yes, the healthcare system is adjusting to the reality of the COVID-19, and we understand that older persons cannot come to the hospital with the same frequency as before this pandemic, and we have adjusted our clinics to deliver much more telemedicine consultations than we used to do in the past. So we have taken care here at McGill to contact our patients through telephone on the days of their follow-up visits, inquiring how they are doing, if there are specific needs, renew medications, and if need be, to refer them to the community services. We inquire also on their family member that is looking after them, because it's so important for our old and more fragile population that depend on a caregiver, that the caregiver also is healthy, because it is in fact a dyad. We are treating not only the patient, but also making sure that the caregiver is healthy, because if the caregiver health fails, both will fail.
Right. So I want to get right into this very important topic now. I mean, you and I have had a few conversations about it with regards to the fact that so much attention has been placed right now on the long-term care facilities and what is going on. And it's just absolutely tragic. There are no words for this. At the same time, there are many, many, many seniors caring for seniors at home. There were people who were on waiting lists expecting to be transferred to these long-term care facilities, so that is now stopped temporarily. There were people who were dependent on what we call in Quebec, the CLSCs, or the public healthcare system, to come and deliver services at home, which in many cases has also stopped. So what can people do? Like how do people cope? What type of support is available? What do they do?
Yeah, I mean, these are very demanding times and circumstances for caregivers and our older population. It's true that the long-term care facilities are having difficulties that is of an incredible level. But remind you that 90% of the older population live in the community in their homes. The large majority depend on a caregiver. The healthcare system right now is all partially dysfunctional, I would say. Because
when you're saying caregiver, though, they're dependent on a family caregiver, on a family member to give them.
80% of the services being provided to let's say, fragile, vulnerable, older adults is provided by a family member. And in about 50-50 between a spouse who have the same age as the older person, and the other 50% is a child. Each of them, of these two categories, have their own specific needs and limitations. The older caregiver spouse have their own health problems, because it's very frequent to have chronic conditions as one ages, whereas the child is middle-aged person,
sandwich generation.
Demands, yes, you live that experience, the demands of their own kids, the demands of life, work, which adds to the stress. So these present times are difficult, extremely difficult for them. I think that our public system has done a reasonable job. They have reoriented their healthcare workers so to minimize the lack of support to the caregivers and the persons that are dependent, homebound, etc. For sure, new cases is more difficult to provide services. Those already receiving services, they have tried to maintain them. Certain services are not available, such as cleaning the house. But in terms of assistance for bathing, supervision, for medications or meal preparations, this has been maintained for the large majority. But what bothers the caregivers is the fact that they are very much confined at home, and it becomes very difficult to be isolated this way, and this is a real suffering, because as human beings, we need these interactions with outside world to enrich ourselves, to give the support. So this is time for solidarity. Family members, wherever they are, they should be calling their parents. They should be renewing ties with them, because that type of support is really essential for keep them going. It suffices to call 2-3 times a week, manifesting that we are interested on them, to give that moral support, At the same time, if it is possible, to do groceries for them. I also tell the caregivers that though we request social distancing, they can go out under the respect of this distance of 2 meters that we have to respect. So they are not in a prison, and if they go out to wear masks, now can they afford to go out, because some of them also have difficulty mobilizing and have the proper balance and strength to do a lot of outside activities. But in general, they should be encouraged not to become afraid, because human beings cannot live by being scared, you know. And also to understand this will end eventually, and already we are seeing the government's allowing to be more, that we can do a little less confinement. I must confess that older persons who have their brain capacity, they are much more resilient than a younger population. They come with their own experience. They have lived difficult moments in their lives, and they can adapt much more. What they cannot tolerate is the absence of contact. So a call, a visit, using, you know, simple telephone call or the new media and new virtual meetings, go for it.
And even and there's the reality too, there's a lot of people that are living alone that don't have family members. So maybe perhaps a neighbor could give them a call, or, you know, like maybe just come together as a society and, you know, just take care of the elders, right? Like, you know, if you just a simple phone call or a wave through a window, but something just to know that they're seen and that they're heard, right?
Yes, and you know, these demanding times have created a lot of positive initiatives. An example being medical students or other students who have approached us to have phone numbers of our very frail older patients, to call them to see what they need, and this is an initiative that came, in fact, from the Jewish General, the Division of Geriatrics under Dr. Olivier Boucher. But our nurses are doing the same by calling and making sure they're doing well. And I think very, very seriously that CLSC's, our community support service, they are also very involved, because this is a time for solidarity, and we cannot leave our older population alone by themselves.
So I want to address the topic of safety, because, you know, the reality is when individuals get a diagnosis of dementia, they don't recognize the facets of how the disease not only affects a person cognitively, but it has an impact on their vision, it has an impact on their mobility, on their hearing. And so now there's a lot of people, again, living at home. There are people living in houses with multiple floors. Some are in apartments. What would you say are some of the areas of the home that pose the greatest risks for injury?
Yeah, this is a very good question. If we talk about injury per se, you know, it is all related to the risk of falls, okay, at that level. Talking about injury, which is, I would say, about 20-30% of a fall will lead to some injury, serious injury, including fracture of a wrist, of a large, long bone, including hip, but also concussions and intracerebral bleed. Thanks God, only 20% will have severe injuries, but we have to be careful, because indeed, due to the lack of paying specific attention, analyzing the circumstances well associated with the dementia, it increases the risk. And believe it or not, but most of the injuries take place in the kitchen, because we are involved doing so many activities, preparing this, doing that, and we do more than one, you know, trying to do more than one activity at a time, and this creates a risk of falls. The second most common area is in the bathroom. More serious illness, injuries take place taking the stairs, you know, because most of the falls and injuries are in the house themselves. And there is reasons for that, because they are more vulnerable, but also there's the environment. I mentioned about in the kitchen, there is many appliances, there is rugs, there is electric cords, and this is when the fall takes place.
Yeah. I think also the in our McGill Dementia Education Program, which when we were we had this wonderful apartment that we were teaching the family caregivers, for instance, how dangerous the microwave could be, where when somebody's going to heat up a cup of coffee, instead of pressing 30 seconds, they can press 3 minutes, not knowing the type of item to place into the microwave. So for example, putting in something that's aluminum or a gold-plated plate. I mean, I actually had one of my kids do that last week accidentally, but I think people need to be aware of, the leaving on stoves or ovens, forgetting that they're on. And then, I think for the bathroom as well, like you say, with the risk of falls, but there's also certain items that people may not be aware of. And what we teach in our program, as you know, is, people could mistake a tube of cortisone cream for toothpaste, or dishwasher aid for mouthwash, right?
The examples you are giving are very relevant because as a consequence of losing cognitive capacity, there is an impact on judgment, recognition, purpose, what we are doing, the action we need to do, for which reason. All of this, if it's lacking, this preparation of the brain for what should be accomplished, leads to certain activities that are very risky. The lack of insight, the judgment in particular, leads to errors such as misinterpreting a tube of a medication with that of a toothpaste. Yeah. So these accidents do exist. And if the person is alone, it is an higher in terms of risk. But because when there is a caregiver, they can be observed, they are being watched and preventing many of these consequences, So there's safety issues. I mentioned falls, but there's other aspects of life that one needs to use our brain as a continuous evaluation of what one is doing, and this insight is lacking. That will lead to errors, that will lead to consequences, injuries, and including taking too much medication or not enough medication that will lead to a deterioration of their health condition. Take a diabetic person, for example. Stop taking the anti-diabetic medications. The sugars will rise, and there will be consequences due to that. So
a common concern that I get from family caregivers as well is the whole aspect of night wandering, where the person who has the dementia gets up in the middle of the night, starts wandering around, or just mixes up the time, so they think, oh, it's at 4 o'clock in the morning, it's time for me to go to work. So I often want people to know that it's important to have night lights in the bathroom, night lights in the hallway, perhaps if they start wandering, to arm their apartment or arm the house, so that if a door opens, they're made aware that somebody has gone out, or the use of the medical alert bracelet with the address and phone number, because that becomes a very big concern for families, right?
Yes, these safety issues are essential because, as discussed by Dr. Gauthier, the disease is a progressive deterioration in the capacities. So as they progress to a more advanced stage, they need more supervision. And it is true that the day-night time cycling can be perturbed, and they can become wanderers. Not all will, but some will. And safety measures will include, as you mentioned, the lighting, even at the stairs, to install railings so they can grab on it to prevent falls. And it's a continuous effort to make sure that they are safe, including drinking something that is inappropriate. There's so many cases, so many specific accidents that can happen that becomes a source of stress to the caregiver. And they need to be trained, educated on these issues in order to feel more confident in themselves, less stress, obviously, and provide proper care at the same time.
Let's touch upon also financial safety, because early on, you're seeing, we discuss this often, we see a lot of cases where early on in the disease, people start making mistakes with their financial affairs. They become victims of potential fraud, solicitations. Can you give some examples and situations where
Well,
because
we see this quite a lot. In fact, there is a chapter in the practice of geriatrics that is dedicated to what we call elder abuse. It can be abused because of physical abuse, because of neglect, but there's also financial abuse. And as one loses its cognitive capacity, our suspiciousness decreases, our awareness that we may be into a case of being abused diminished, especially in those who are more empathic and older persons. They provide more confidence in those who care for them, and they can be abused because someone has bad intentions. And the best way to protect them is indeed to prepare a will with a mandate, so that eventually some family member that they have previously decided who should be the mandatory, they can take over to prevent fraud from taking place, to prevent people from stealing your money. Because even and I must confess that the majority of the people who are abusers are those who have gained the confidence of the person, the caregivers included. Because you can give your caregiver the permission to use your card to do the groceries for you, but that person might use the card for other purpose. And the older person with dementia might not be able to pick up this for a long time, but there is a family member involved. They can oversee how the finances are happening or taking place, and protect the older person from these frauds.
I asked this question to Dr. Gochi last week, and I'm going to ask it to you again, because again, for the family members who have to make the decision to take away the keys to the car or take away the credit cards and debit cards, you're taking away the independence of the person that you love. I had to do it, and I thought I reached a point where it was just tough love. Like, my mother was furious with me. She hated me. But it gets to the point where my number one priority was safety. Would you agree? Like, at some point, family members just have to just say that's it?
Yep. Unfortunately, it is the case, because there is risks involved in allowing the older persons whose judgment is failing to continue driving, or to continue deciding on investments. The errors are so great that they can lose all of their assets, and they don't realize that until it has taken place. Same thing with the car accident. So I must confess that the law in our province of Quebec protects the professional if he feels that the person should stop driving. So we just need to inform our régie, our organism responsible for driving, that this person should not be allowed to drive. And I have to tell this to some of my patients, and I tell them, look, you are allowed to contest me, but you have to prove that you are capable. So the government will ask you, if you really want to drive, to undergo a road test. And this sometimes make them realize that they have reached a point where they become dangerous. And those who go through the test, then we have objective evidences that they can do it or not do it. So at the same time, at the beginning of dementia, at the earliest stage, they can still drive under limited conditions that I impose to them, and they are most of the time agreeable to the idea of driving, for example, just during daytime, out of traffic hours, in a very restricted area in which you are very confident, because the accidents happen when their judgment is affected. And for example, when they have to change directions quickly, there is some obstacle appearing suddenly, this is when the accidents happen. And to avoid
that whole reflexes, right?
Yes. Yeah. And to avoid these under restricted conditions for certain time is still possible, because as you mentioned, it affects their autonomy, their self-confidence. To remove that capacity is not a right, but it is something that is part of our autonomy, and we are very sensitive to it. It's very, I would say, for us as a physicians to remove that to the patients that we care for is a task that's not very pleasant.
I mean, one of the advice that I like to give people, I mean, if only everybody could have a geriatrician like you, that's so compassionate and willing. But I often say, like, let the doctor help make that decision, right? Like, I mean, because if I, as a family caregiver, say to my mom or my dad or my husband or wife, say, you can't drive anymore, or you're taking away your cards, they're going to look at me with. But if the doctor is the one who says that to them, that the time has now come, I feel that it would probably facilitate the
because
process.
I fully agree. I don't live with the patient. So, but a spouse or a child that has to remove that from the parent, let's say, or the spouse, they're going to be facing opposition all the time. So leave this to the professional because would relieve a lot of pressure on the caregiver herself. And I think that one way of determining how confident is the caregiver in preventing the person with dementia to drive is by saying how comfortable are you if your husband or if your wife is driving and you are beside? Are you scared? If they say that, then I have to cancel the license,
So I have one last question for you. Okay, and here's a good one. So I'm the caregiver and I'm now sitting in your office in front of you. You've just given my mother and I the diagnosis that she has Alzheimer's disease. I wish it were the case where my mom could be waiting outside and it's just you and me, okay, talking about what's next. So what would be your most important advice to me as a family member on how to navigate this journey?
Yes. I mean, I always take a few minutes after doing my assessment to speak with the caregiver, the family caregiver, obviously, because the disease is something that is progressive. It's a progressive deterioration over time. And they should understand that the situation that can be handled for the present time will change and will request more skills, request more time, commitment, and they shouldn't be facing it all by themselves. So having proper education, proper training is necessary because knowledge gives us the capacity to understand and develop that self-confidence to prevent the stress related to be a caregiver in which the demand is increasing over time. At the same time, it is important that they recognize themselves, their emotional state, because as the demand increases and the stress is there, we can start feeling overburdened, tired, and discouraged, anxious, depressed. I have seen all of this. So they have to recognize their own symptoms. And we cannot face a disease like that all alone. They have to have some family member as a support, as a companion in this process, and request assistance, professional help to maintain the person at home with the community service that there is available. And they should, as the dementia progresses, the person should have a professional dedicated, a case manager that the caregiver can relate to when things are getting out of control or the demand increases. The caregiver needs to be prepared for such a task. It's not trivial. It's extremely demanding. It's a continuous availability that can bring a lot of stress. You mentioned about a person who develops a wandering behavior. This will affect sleep. So it won't be long that the caregiver will be without proper sleep and extremely tired, and then her capacity to care will automatically be decreased. It's human. So this, facing the disease, you need to do it with knowledge and support to be able to go through until such time where they would need to be placed, because the care at the end is a very specialized care, skilled care that cannot easily be provided at home. It's why exist these long-term care facilities with their own difficulties, but some of the professionals, they know what they should be doing and how to address the need of the person that is at the end of the dementia process.
The biggest objective of the McGill Dementia Education Program is exactly that, to highlight the importance of education and support. And, I founded it with you and Dr. Gauthier because of everything that we're doing is because of my own experience as a caregiver, not listening to any of that part of advice and suffering a severe nervous breakdown as a result. So, education and support is key on this journey.
Indeed, it's why I embarked so naturally, because you had this great idea, and my job was simply to accompany you in the process with the resources that McGill has available. And many people have contributed to make the Dementia Education Program a success. And we have many plans to continue developing it to meet the needs of the caregivers. You are not only the founder, but the ambassador of such initiatives. So I'm very happy to continue to contribute and support all of your activities related to that. Yeah.
Right. Well, thank you so much for joining us today. And like you mentioned, this webcast, everything that we're doing is really thanks to the generous donations of many individuals who've contributed, family foundations, private individuals who've been touched by this disease. And if you like what you're seeing, we have a donation page on our website. Please consider making a contribution so that we can keep doing this. Next week, we will be discussing coping with grief. My guest will be Corey Sirota. She's a clinical social worker, lecturer at the McGill School of Social Work, and she's also the co-host of the CJAD radio show, Life Unrehearsed. If you would like to have more information or see previous webcasts, please go to mcgill.ca/dementia. And if you have specific topics or questions that you would like us to address during our weekly webcasts, please email us at dementia@mcgill.ca. Until next week, please take good care of yourselves. Thank you for tuning in.
Bye, everyone.